My dear panelists with me here. On my right is Dr. Adel Atribi, consultant interventional cardiologist from Cairo, Egypt. Dr. Gabriel Gasparini from Italy. Dr. Abdullah Al-Khudair from Saudi Arabia. And Dr. Badr Zahrani from Saudi Arabia. So we're just waiting for the connection with the Alqassimi Hospital. It's going to be a case about left main intervention. So let's start with Dr. Gabriel. Gabriel, I mean, when you hear about left main intervention, I mean, we saw some lectures today. So what's the most important in your mind?
Yeah, first of all, when we have to deal with left main intervention, independently of the involvement of the bifurcation, is to consider use of imaging. I think this is one of the most important aspects that we should consider before doing that. Not only just to assess the severity of the lesion, measuring the area, but also having an assessment of the bifurcation involvement. So when you have to deal with left main intervention, we should always consider use of imaging.
Okay. Are we ready for the live? 1 minute, huh? Okay. Adel, any comment about left main intervention?
Well, the left main has very peculiar things. At first, it's the vessel that arises from the aorta directly. It bifurcates into two major vessels, unlike others like diagonal and LAD. And its diameter is sometimes exceeds the diameter of the balloons we use, like 5 or 4.5. This is one thing. I agree totally that imaging is a must. In aortoiliac and the aorto-original or ostial lesions, I think IVUS is more superior than OCT, but imaging is a must in most of the cases.
Badr?
Yeah, I mean, talking about left main imaging is a must, as you talked about. I think the major discussion is also which strategy you're going to use if there is a bifurcation lesion. I would support the idea of DK crush for if there is a real bifurcation. If you decide to do a two-strand strategy, imaging is a must, definitely pre and post. And optimization with all the part and final part too. I think heart team approach is very important also to balance the and decide should the patient go for CABG versus PCI. And if you see the latest guidelines, they emphasize about left main to have a heart team approach and discussion every single case. So.
Okay, thank you. So are we ready? Okay.
Down, please. Drop it down, please. Okay.
Assalamu alaikum, Arif. Good morning.
مرحبا عليكم السلام ورحمة الله وبركاته. Muhammad, how are you, my dear? And welcome back to Alqassimi Hospital. Good morning, everyone. And it was a bit hectic here. Sorry for this. Actually, without further delay, I'd like to say welcome and thank you for inviting us, GIS, again, to your prestigious meeting. I'm really happy. I wished I would be with you in the opening ceremony, but we are with you anyway. And I allow myself to introduce the team: Dr. Wael Abbas Ahmed Khashaba, Dr. Ayman, anesthesia, Priyesh, Walid, Ashraf, Pimi, Doni. I have so many great team around me. And yes, so it was really a bit adventurous moments in the past 10 minutes. Sorry for this. But let's go and start the case presentation, and then we will update you what we had. Okay, so Dr. Luay Abu Doka will introduce the case, please.
Thank you, Dr.
One
Arif.
balloon.
Share.
No, which one is the?
Good morning from Alqassimi Hospital in Sharjah, and congratulations for a successful meeting. I will start with my case.
The jail.
A high-risk complex PCI to left main.
Which one is this?
We do have an elderly gentleman. He is 74 years old, and he has a past history of hypertension, diabetes mellitus type 2, dyslipidemia, and chronic kidney.
J.
He had PCI to proximal to distal LED 10 years ago. Out of the country, we have no report for this PCI. And recently, he was admitted with acute coronary syndrome, non-STEMI, and underwent diagnostic coronary angiography.
Okay.
On examinations, he is fully conscious, oriented, and physically active, vitally stable, no carotid bruise, intact all pulses, no added sounds, clear chest with no lower limb edema. When it comes to his medication, he's in the usual, dual antiplatelets, beta blockers, bisoprolol, statin, high-intensity dose, valsartan 160, SGLT2 inhibitor, the dapagliflozin 10 milligram daily,
Okay.
and
First.
sitagliptin.
Now we can take the other way around.
And when it comes to his labs findings, his hemoglobin is fine, 13 gram per deciliters, platelet count 268,000, creatinine 149 millimole per liter. His high sensitivity troponin came back to normal. It's 50 yesterday. His hemoglobin A1C is 7%, and his LDL cholesterol is 2.1 millimole per liter. As you can see, he has a normal sinus rhythm with a non-specific T-wave inversion on the high lateral leads,
16.
preserved
And the
airway
1.5,
over the
please.
ECG. His 2D echocardiography showed severe LV systolic dysfunction. The left ventricle ejection fraction is about 30%. There is arresting wall motion abnormalities in form of hypokinesia. He has a grade 2 diastolic dysfunction, normal valves in morphology and structure, and there was no pericardial effusion. This is his diagnostic angio, recently done. You can see in this spider view that we do have a critical ostial LED lesion, then a severe proximal lesion, calcified vessels. Another proximal LCX lesion, severe. We do have two OMs, both are diseased also. We can see the LED stent clearly. Again, in this
220
lateral
balloon,
view.
please.
The RCA has a CTO,
Okay. 6, 8, 10, please. 12,
not that much.
15, 16.
Retrograde filling,
Safe,
renotrop
please.
0 to 1.
Down. Down.
12. Okay.
Again, please. Again, please.
So when it comes to patient preparation, after we discussed the case at the heart team meeting, and it was turned down by the surgeon due to a poor target,
Again, please.
we sit down with the patient and his family, and we explain in detail the procedure
Down, please.
and the risk, benefits, and everything.
Again, please.
And as you know, this patient is at
Two balloon,
risk
please.
of developing contrast-induced
Down,
acute
please.
kidney injury. He has an intermediate risk for contrast-induced acute kidney injury. It was 6 when it was calculated. So he was prepared with the hydration with the normal saline, 1 ml per kg per hour for the last 12 hours just before the angio, the PCI, and we will continue for another 24 hours. Also, we used the renal guard system to increase the urine flow rate, and we do have a good experience with this device. It prevents the contrast-induced nephropathy.
And I need another DCB balloon, please. DCB.
We had 2 axes.
225 or 225.
For the procedure, we aim to go through
Or
the
2.
radial artery, the right radial artery, 7 French, the glide sheath slender. And we used also a mechanical support up front, which is IVAC 2 liters.
Can I have a Sion wire?
So we want to throw the right femoral artery with a 17 French sheath. Dr. Arif now is doing
Can
the
optimize it later. Can
LCX
optimize
after
it later.
using
Okay, take
imaging.
this out, please. All right.
We will
So
see
let's
what
have,
was done offline or
see
before
on
we
wire
go
and go to Spider, please.
live.
Okay. We take the
يبقى 221.
Okay, Arif.
So, yes, Mohammed.
So we listen,
So,
we listen to the
actually,
story. I mean, do you want us to discuss here
that
with the
was
panelists, or you want to show
10%
us
of the
something?
story. That was 10% of the story.
Yeah.
So the rest 90 will tell you now. So this patient is basically a high-risk case, quite severe LV dysfunction, age-wise 72 years old, chronic kidney disease with creatinine of 150 and reduced GFR. The thing is, he has CTO of the right, severe stenosis of the mid-LCX, and ostial LAD is severely diseased. He has severe instant or moderate incentric stenosis. Distal LAD is also severely diseased. So all in all, the surgeons turned him down because of poor distal LAD culprit due to the metallic cage. And what we thought, we will do him under left ventricular support device, because this is a case that you predict kind of bad scenarios. So we were lucky to have IVAC 2L here in place in the right femoral. I don't know if you can see. Can you put the camera here, please? Can you move the camera to my hand, please? Yeah. Okay, so this is IVAC, pulse cath. This is 18 French catheter through the right femoral artery. And we had predicted that might be something. We put a sheet for femoral vein for pacemaker, temporary pacemaker access, just in case, and that's what happened. We needed it really urgently. And we have a 7 French slender guiding catheter in the right radial artery. So what we did, we thought we'll go 1 hour earlier, 45 minutes, and fix the circumflex that involves a quite reasonable size second OM2. And can you show me, please, first? So this was the right again. You have seen this. Next. So our plan was to go image guided. The circ is really not a small circ. You can see, I don't know the size of the right much. There is a poor collaterals, but looks almost co-dominant, if not left dominant. And this second OM and first OM are diseased. So we thought we will just do a DCB, and we have done with a 2 balloon. Next, please. So we thought to finish this one first, the circumflex, and then come up to the left main. What happened is this patient was a recent acute coronary syndrome, and this is a situation where you sometimes underestimate the plaque burden, the severity of the disease. We did imaging OCT. It didn't show that significant calcification that could require calcium modification with a ROTA or IVL. So we thought with a kind of scoring balloon, and we did that. Next, please. This is the wiring of the OM and the circumflex. And no, go back, please. That was before that, please. Before that. So what we have done, I'll show you the scoring balloon. Please go back. Once we wired actually that lesion, it became to TIMI2 flow, and patient went to hypotension, bradycardia, and we had to place immediately a temporary pacemaker. We ballooned that OM and go back, please, with a 2 balloon and followed by DCB to that OM. Next, back, please, before, please, one more back, before with a scoring balloon, please, go back. Okay, this is the scoring balloon. So you can see this, it didn't open first of all, and then after going to pressure of 16, it opened actually. Then the patient was a bit restless. Next, please. Then the flow, this was the flow afterwards. The TIMI flow in the OM got impaired. We started ballooning that. Next, please. This is the 2 balloon, 25 or 20. And then next, please. So, next. That was DCB at 30. And then Next. So here was TB2 flow. We started with the pressure, with inotropes, and we had the support of the IVAC, but we require really maximum support. So that was a stent, which is the Frontier, the new generation of the Onyx. It's really a great one, was deliverable easily, and we will talk about this stent later on. And you can see that the flow got a little bit impaired after this all kind of plaque embolization downstream. And then what happened, that OM got closed. So we had really challenges to get an access back. We tried once, twice with the many wires. And then we thought to go under the struts and with the one balloon to open up, just to give a little bit to breathe to that OM. It didn't work. Then we used a Sasuke dual lumen catheter, and with the Fielder XTA, I was able to recross that OM, and I did ballooning with the 1 and 1.5 and a 2. And then I got the flow back to that OM. Next, please. So far the pressure now is back. It is 160 with few ectopics. Next, please. Next, please. Next, please. Next. So without any delay, we have to take care now of the LAD. Next, please. So a lot of things, Mohammed. Now I would be more than happy to hear from you and Dr. Ahmed, and while we'll keep on talking to you about your strategy, what would have you done differently from your panels? And I will start to try to recanalize or go through that LAD in the tough angulation. I will take one shot, please, Spider. Can I see before you go further? I'll give you one injection here. Next, go. So you see that angulation, it's a quite ugly angulation. I don't know about how much calcium burden is there, but we will have to deal with it. So I'm taking a Sion to cross that one, and then maybe exchange with we do an image if possible, though I think it is going to be difficult, but let me try.
Okay,
so
Arif,
the floor is yours,
you can try cross that, and we'll discuss with the panelists about what happened and what's their strategy next. Gasparin?
First of all, I do agree with the procedural planning, because we are dealing with a patient with a 3-vessel disease, low ejection fraction, and complex coronary lesion. So considering left ventricular assistance, it's a good choice, like in this case, because it's a sort of unprotected left main. I mean, because of
and it's left dominant
dominance with RCA occluded. Then fixing first the circ could be the right choice, because
Are you quoted, please?
The most complex lesion seems to be the lesion that involved the LAD.
Yes,
so
please.
having treated before the circ could help you to go on with the LAD treatment, and then especially if you have to treat a left main. I mean, because the lesion of the LAD, it's very close to the left main. It's an ostial LAD lesion, so it's a sort of left main equivalent. So finally, we will discuss about the strategy for treating the left main. So starting with the CERT is the right choice. Now I will spend just a few other attempts in order to reopen this obtuse marginal, because it seems quite big. Yes, we also can discuss about the best strategy to deal with this bifurcation, to start with a provisional like they did, or to consider an upfront to stent strategy. But we can discuss together about it.
Abdullah?
So yeah, this is where sometimes unanticipated events can distract you a little bit, and that's what happened with the OM. I mean, the difficulty here is multiple steps. One of them is planning what to do with the ostium of the LAD and whether or not the left main is involved. Wiring was expected to be difficult, but greatly done here. A few tips would be
Can I have,
angled microcatheter or
balloon,
using
please?
wires that have less tendency
give
to
me imaging,
prolapse.
give me an OCT
And then the
to try
question
if I
is
can cross.
the stenting
Try.
strategy of the LAD to left main and whether, I mean, one scenario is to try to nail the osteum with all of its, I mean, the strategy has some known limitation which were discussed in the previous session, extending all the way to the left main, or sometimes I've seen people do like a floating stent. And again, there are some pros and cons of this technique. So excited to see what the imaging of the left main shows and to help us plan and choose the right strategy.
Arif, what was the wire you used?
This was Sion.
Okay, so
Normal Sion,
what's you gonna
standard.
do now? Balloon first and then...
I was having some challenges to cross that calcified ostium, but luckily it went in. So we need always some kind of, you know, we say tawfiq min Allah. So yes, we thought we will take another 10, 15 minutes of blessing. We need it in this case for sure. And now, center, please. So now we will try to do a 1.5 balloon just to be able to cross my OCT if possible. It is quite angulated, and I'm a little bit doubtful that OCT may get stuck, the OCT catheter. So I'll not try to create a lot of things in case I need to go with the rota. Okay, let's go. It's going easily. So I'll just go to 14 to create a small channel down. And then if needed, if not, IVL could be also an option. Again, please. So, though we believe IVUS will have a role in left main, we know that. Down, please. But to quantify this calcium and use the calcium MLD max scoring system with the Ultron would be really interesting to see and put a strategy of kind of stent and length of the stent and all that kind of morphology understanding. This all will affect our decision at the end. We don't forget that there is another lesion proximal to the old stent in the mid segment of the LAD. So that's what I'm doing now. We'll take an image. I hope.
Gabriel, any preference, IVUS or OCT in this scenario?
No, I mean, in this scenario, no difference between IVUS and OCT. Maybe some concern because of kidney disease. It could be better to use IVUS because you don't need to inject contrast. And then if you have the need to evaluate the left main, IVUS could provide you better information. But anyway, in terms of evaluating the calcified lesion, OCT could be better, but you should decide it accordingly to the patient and the lesion that you are going to treat.
Go to PA cranial, please.
What was the balloon
Actually,
Arif
may I
used?
comment on this? Our patient today, we are using a renal guard system, and we saw that using OCT in this lesion would give us a better idea about the mechanism of treatment of the calcium, either with only atherectomy
Can I have
or
PA caudal, please?
IVL plus atherectomy.
So this is the
So
OCT
as you
catheter.
see,
Did
I
you
have
cross?
some problem even after that 1.5. It's not possible to cross with the OCT with this. So what I could do, I'll try. I have, for the educational sake, actually an IVUS ready also, with a better support probably. I'll try. I'm not guaranteeing to see with the IVUS, but I will see if I can do imaging before. If not, I'll have to go with a 2 balloon and do more dilatation. So what do you think, Mohammed? How do you think your panel? Do I go with the IVUS directly, try, and because you know the catheter is a little bit more hard, more stiff, so could cross.
Would you use,
Or would you go with the 2 balloon?
would you use debulking from just to start now?
It's an option, but if we can get an image and the balloon can cross, IVL could be really an option, but IVUS may be less helpful. We'll see. For the deep calcium, I mean. We'll see if we can buy that. But if the balloon crosses, IVL will be also a good option.
How about just doing the OCT on the circ wire? Because we're interested in the left main and the circ ostium. So Maybe that will give you some information.
Well, IVUS will give you the same now, if I can. I have already IVUS catheter in now. We'll see.
I think looking at the anatomy, in this patient per se, you do have a heavily calcified lesion extending all the way from the left main to the LAD. You have a creatinine in 140, so I think I would lean towards IVUS. It's going to assess the left main better than OCT. And also it's going to avoid contrast from given. I think I would agree with just dilating the ostium LAD with a small balloon that just allows you to
Can we do a run,
advance the
please?
IVUS and to
I
avoid
can go up
dissection.
to here. Let's have an IVUS, please. Ahmed, maybe you can.
Arif,
comment
it's
on that.
Adil Tribi talking.
Stop.
In your experience, the profile of the IVUS is better than the OCT. Can you elaborate on this?
1 second, please. Okay, we are. 1 second.
The profile of the OCT is
Can we?
less than the profile of the IVUS catheter, but it is more flexible and more less supported, if you might say. So whenever you need some support, IVUS can go. As you can see here, the IVUS catheter is pulled back from the LAD. You have a severe calcification. This is the wire of the circ. So actually what we have the information from is that the ostium of the LAD is heavily calcified with more than 270 degrees of calcification. If we can have the pullback to play back again, please.
Can you show the image again?
Yes. Can you see it now?
Yes.
So starting from the proximal part of the LAD, which was previously stented, coming back to the ostium, we have like 3 stent, and this is back, and here comes the ostium of the LAD, and as you can see, it's heavily calcified ostium.
IBL can do the job here.
Yes.
Good cross. So I think IBL should be not a bad option. Can I have a 3, please? IBL, please. 3 IBL, please.
So
Because
you definitely hear from
the 3. I'm sorry, Ahmed, but distal is a 3. I will try to use that balloon for the distal and the ostium. It is quite tight, so 3 should be sufficient. If needed, a 3.5. That's a question that to be answered. But I think 3 can do both jobs for the distal part and the proximal part, and then we'll post-dilate. Our plan so far is, if nothing goes really differently, to be a provisional stenting. And I saw the left main is maximum diameter, something like 5, I think. Ahmed, what do you think? So we could go with a stent with a maximum 5 there, but we have to check the length. Probably we'll go with 3.5 distal, maybe 2 stents, one for the distal part and another one for the proximal part. So
what about the ostium of the circ?
Ahmed.
Can you elaborate? The ostium of the circ, we really
We
have
have taken
on
a
it.
shot. Can I see one audio codal, please? Yeah, I mean, there is a disease, Dr. Adil. There is 25 to 30% disease at the ostium. It's not significant. But again, this is something that we have to evaluate, assess after dilating the LAD ostium. We don't know how much of this carina shift will take place. But I hope with this kind of plaque modification, fracturing of the proximal calcium, we reduce the risk of the carina shift and having a better stent expansion there. But we have to wait and see. This is really a case that the scenarios are open to all aspects. I mean,
And we had this information about the ostium of the LCX from the first OCT run that we did before tackling the LCX lesion.
Hope afterwards.
Arif,
Can I
what
have the
you going to
balloon,
use now? A rotablation or?
I don't think I need a rota at this stage. I think a balloon can cross nicely and we can get the same effect. This is, especially I did see them some kind of fracturing with a 1.5 balloon even. I saw one fracture there, so I don't like to go with a rota now at this stage.
Gabriel?
Unless this balloon doesn't cross. But
I agree with the strategy to start with a balloon-based technique, because accordingly to the IVUS findings, okay, we have to deal with calcified lesion, but we can appreciate also several reverberation during the IVUS run.
True.
That means that
right.
the calcium is quite thin. So we are treating not a thick calcification, but it seems to be
So it's crossing.
thin
Safe, please. Go
calcification.
PA cranial, please.
And in this case, a balloon-based technique using a non-compliant or a scoring or cutting balloon can be enough to achieve an adequate
So
lesion
It
preparation.
will
Can I
depend
see
on
small
the
test, please?
balloon expansion and see it. If it's not expanding, so
Yeah, you are right, but IVUS
in
finding
little.
seems promising to use a balloon-based
let's
and no
have
need
here,
for
please.
root ablation.
Yeah, ready?
Then another comment is that I usually prefer to perform, once I have IVUS, I usually to perform an IVUS run in both branches, LAD and CIRC, before deciding which kind of strategy to use in terms of provisional or double kissing.
Okay.
And
6, please.
I would measure the area of the ostium of the CIRC using 3.5
back.
as a cutoff to decide it
And use here
if
again.
to treat or not to treat.
there is also the issue of the instant restenosis, right?
Can you repeat the IVUS run back
Arif.
again, please?
Yes, sir.
What's this balloon?
This is the IVL 312, and we did at the edge of the stent, one run. And you know, we can go up to 8 cycles.
Stop at
This
the
is the
ostium.
second cycle. I'll do throughout this vessel and then more at the ostium. Again, please.
Okay. Do you plan to do anything for the instant restenosis and the distal LED, or?
Not at present time, because I think it is a moderate, maybe the DCB could be enough later on. But for the time being, I think patient underwent a lot of things. So we come out as soon as possible. That will be my strategy now for the time being. Down, please.
So if you can have a look to the IVUS image now, coming back to your reverberations
Can
in
you
the
come
ostium.
PA portal, please?
From here, we cannot appreciate a lot of reverberations, and this speaks of a deeper calcium that
Go, please.
and thicker calcium that we might think. So this is why the decision for going with a calcium modification in terms of IVL was taken.
We can see how the balloon expanded actually at 4 atmosphere. There was a tight waist there. Go to 6, please. Right. We'll do one more time, please.
There is
We
still a
have done
waist,
so
huh?
far 4 cycles. Go, please, again. So I need then a 3 non-compliant balloon, please. 25 or 20.
From here, Arif,
please.
we're not sure.
6.
Is it fully opened or not?
Sorry?
The balloon.
It
Is
is open, really. I can see, I'll show you again here.
Can you explain,
You can
Arif,
see the balloon here.
the size of the balloon to the vessel? Is it 1-to-1 or is it? Can you explain this to the
As I
for the
said,
IVF?
Dr. Adel, usually it is 1-to-1, but because I had distally 3, so I'm trying to utilize this, and we have really tight lesion. So 3 should be sufficient. Up 6, please. Down. So 3, usually from our experience, is enough in this situation, for instance. If needed, we can still go with the 3-5. Okay, but the balloon is open nicely. I'll do post-dilating. Go, please, again.
So
Also,
how
the
is the
coast,
patient
you know,
tolerating
you can see
the,
the balloon is very nicely open.
Yes.
and is he requiring any pacing at this point?
No, he is on his own rhythm. Blood pressure is about 120, if I'm not wrong.
Yes.
We can show the hemodynamics, please. 6, please. Down, please. So, small test, please. Small test.
Yeah. Pressure stable.
All right.
rhythm
So
stable.
I think we are good. Can I have a 3 non-compliant, please? So save that one and show me, please. I don't want to give now much injection into that dissected part, maybe. So I will do just a small puff, and I can save it and show it to you without using a lot of hydraulic pressure. You can see it open nicely. The geometry of that is good. The LCX is okay. I don't see a lot of plaque shift at this stage, but still we have to go with a non-compliant balloon and see.
Arif, can you explain again what's the size of the proximal LED and the size of the left main on your imaging?
Left main, I could tell 5. Distal, mid
we
LED
measure?
was 3 to 5, but we can show you the imaging again.
And Dr. Arif, how many shock wave runs did you do?
I gave 9 runs, sir, from middle AD, proximal, and ostial. So this is a non-compliant balloon. PA cranial, please. We have to post-dilate that part to have really our stent deliverability, not to have a lot of chance. See, it went very nicely in actually. Small test, please.
So the left main proximal reference segment, as you can appreciate here, is just approaching 5.
Okay.
It's 4.7 by 4.8.
10, please. This is a 20 millimeter balloon length.
30.
Okay.
30.
30?
Yes.
20, yeah, okay.
Can you give us the measurement for the stent,
please.
please, downstream? Stent, the
So this is
proximal end of the
20.
stent.
This is 3.5, Arif?
Go to PA caudal, please. PA caudal. I'll try to make a measurement also with the balloon, and we have it, certainly an image, but I will take
More.
More, please.
More distal, a little bit more distal. Distal. Yeah, more distal a little bit.
This is 20.
Yes,
test,
here.
please.
Yeah,
One test, please.
here. Measure, just measure.
So this is another 20, so 40, 38 to 40 something. Okay, let's go for 6, 10, 14, 16, 18, 20. All right.
The proximal end of the stent by IVUS is 3.25 by 3.1, so
Down,
it's
please. I think we can take, what do you think, 3.5, 2,
3.5 should be fine. Yeah.
for the distal part?
Yeah.
And then
Gabriel,
maybe a 4 for the proximal.
what would you do strategy?
4.5.
We'll do
The left main is
provisional at this
4.7
point.
by 4.8, so
I
nearly
mean,
5.
giving the information
So we'll
that
take a 4 stent.
in the
Four to
circumflex
have
atherosclerosis is
4.
around 30%.
Because
as you
we are
said.
using the
Can I have
My
3,
strategy
5,
now
22, please?
would to use IVUS once again to evaluate for achieving a good plaque debulking in terms of creating cracks inside the lesion, and then pushing IVUS just a little bit further to evaluate also the in-stent segment.
Can I have
Because
PA
if we
cranial,
have
please?
to deal with in-stent
PA
failure,
cranial, please.
with a stent failure, we have also to understand why. It
Go,
could be
please.
related to a neoatherosclerosis because the stent was placed more than
Show,
10 years
please.
ago. It could be related to undersize or under
Inject, please.
expanded stent. So it's important also
Well,
to have this kind of
I think I
information.
can
And then
go
also
now with
I
the
will finish with
stent.
IVUS run into the circ before deciding
We
which
can have a quick
strategy
IVUS.
for the left main.
Let's satisfy
So,
the
Arif,
audience. Yes.
or OCT.
There is a suggestion from the
OCT?
panelist here.
No, I don't like. Okay,
Arif.
give me an OCT. Yes.
Can you hear me?
Yes.
So the
OCT.
suggestion from the panelist here is to do IVUS once again, do it from the mid LED just to see the instant restenosis. I know that you're not going to deal with it
It's
now,
OCT.
Yes.
but we want to see the instant restenosis there. What's the mechanism? And then do another run in the ostial circ. Do you agree with that?
First of all, Mohammed, I will do it for the sake of now education, just to see what is happening. I don't think that will affect my strategy much. First of all, I had information from my previous IVUS at the proximal stent. Second, there is no significant instant restenosis. So I don't think there is a failure of the stent. This is a new lesion there. Third thing is I have really good lumen gained angiographically, but I will do an OCT just to see the effect of the cracks and everything and do some measurement if needed. But I think I have already I was able to have some measurement with my balloon itself. So very simple steps sometimes helps you.
Okay, so OCT.
And even in terms of detecting new atherosclerosis, I think OCT is much far superior than IVUS in this regard.
Not crossing.
I have some.
PA caudal might be helpful.
I don't know.
No,
I don't think
it's going to the CX.
Okay, it's looping actually. It's again, because of the angulation, it's really not helping much. So if you want, I can do a run of IVUS one more time. It's quite sharp angulation with calcium chunk there. Sometimes it's really not easy to overcross with the soft tip of the catheter. That's what happened initially when we use the IVUS. So this is good to also, understand the role of each tool, and limitation of each tool. This is really good to demonstrate this kind of things. So
Actually, this,
We don't do this normally to open up IVUS and OCT, but as I said, it is really for the GIS and for Dr. Mohammed.
Show IVUS screen, please.
All right, so here is our IVUS catheter now. Come, please. We are in the middle part of the old stent. That's enough, I think. Otherwise, we'll miss. Okay, let's go, please. Come. We have not much of time, I think. We have to. Okay, so this is the stent you see in the mid. It is well opposed. There's no such malposition. Some calcium is there in the mid part of that stent, but I wouldn't touch it. We have good MLA. So I'll start my stent really from the edge of the proximal stent. This is the IVUS again. Okay.
And the mechanism of instant restenosis is definitely a new intimal hyperplasia.
So can I have a 22, please?
Without a lot of
Can
new
I just
atherosclerotic
the
changes.
edge and the diameter. 1, 2, 3, 5, please. 3, 5, 22, frontier. So this new stent or delivery device of the old Onyx is really
Can we see the run?
described as
Can we see the
having-
run again, Arif?
Sure. Can you play again on the big screen, please, the IVUS?
give the
So 22, please.
22.
And we'll take another 22, 4, please. 422, a second one. So we thought that for this angulation, we need really the really extreme deliverable catheter and stent. So we thought this is really going to be a good opportunity to use this frontier with the new delivery system and dual flex balloon.
Actually, just to mention, this is the launching of this frontier in the MENA
yes.
region. This is the first case in the MENA region to be done. And we thought to keep it for
You
the
always
GIS.
have the first case.
Come on, Mohammed. But let us say first, let us cross that
Yes,
region
yes,
because
yes.
I am a bit.
I just
skeptical
wanted to
angulation.
mention.
This is quite tough angulation,
Yes.
actually, and
So
we'll
you will
see
choose
that,
the 3.5 stent.
22,
Okay.
and I'll follow it with the 422 to the left main.
So they claim that it's having the lowest crossing
Yes,
profile
please. Yes.
and
Yes.
dual.
So this is going to be my left main to here. So I'll take that as a landmark. Save that one, please. So this is 22. I take another 22. So if I go from here to here, this will be another 22.
Yes.
All right? Agree, everyone? Okay. Let's go to 4,
Agree.
6, 8, 10, 12, please. Another 4, please. 22.
Okay.
Yeah, go. It's open nicely. You see the impact of this?
Yes.
Go 12,
15.
14. Down, please. So it's really helped us a lot to have a full good expansion, I think. Okay, again here, please. We'll do some more pressure here. 16, 18.
Actually, the balloon is, it's very good.
Amazing. It
Yes.
moves really easily, yeah?
The balloon is,
I
I can feel it.
I can't agree more. Down, please. Okay, open up, please. The 4, please.
It's ready. We're ready.
Abdullah, when you do provisional stenting across, like LED left main, do you go and open the struts to the circumflex?
Yeah, so I think it depends on the acuity of the situation and on the ostium of the other branch. So those are all factors that play into the decision. So sometimes if it's an acute coronary syndrome, then try to maybe keep it minimalist and then maybe optimize later on once the situation is more stable. If the ostium of the other branch is clearly healthy by angiography and by imaging, then
I think
that's
the
again
surface is okay.
one of the reasons why.
So you reevaluate
But in general,
after
I
the
always do.
stent.
And use FFR here.
Gabriel?
Not necessary.
Yeah.
And geographically, there's nothing.
Opening the struts of a side branch when you do like a left main LED?
Not systematically. I mean, if I decided to start, with the provisional, I didn't touch
Really
the
easily
side
going,
branch
yeah?
before stent implantation.
let's have,
Then it's
Elio Pena,
related
please.
to the findings. Sometimes I can
Small test, please.
use functional assessment
back
in
little.
case of need to evaluate, the need for dilatation of the side branch
Yes,
and the
please.
struts across the side branch, but not systematically. I always finish with the pot, but not necessarily with the side dilatation.
please.
If I go just for
The
stenting
cranial,
the
please.
main vessel, I finish with the pot. If I do a side branch dilatation, I
Yes,
prefer to
please.
do pot, side pot.
Yes, please.
In this case, what size of balloon you will use for a pot?
Oh, it's a huge the left main, I think at
please.
least 5.
Yes, please.
If you're going to dilate, which you undersize for the circumflex or you one-to-one
please.
balloon?
Yeah, this is a good question.
Iliocranial, save that one, please. Iliocranial. I
It
need the
could be
5
better
times 5,
to
10,
undersize
12.
just a
12,
little
please.
bit to open the struts and to
Take a shot, please.
reestablish a good flow into the side branch.
We are far
if
out.
if it's needed.
Okay.
But
Yes,
one-to-one can lead to a dissection of the ostium of the side branch. So
Yes,
it
please.
could be better to undersize just a little bit
Yes,
the balloon
please.
for the side branch. In
So Arif, this is a
I
4
think
O
was much
stent.
better in this patient.
Yes, please.
Arif,
Can you go to
size of the
iliocranial
stent?
again? It's a 422. Frontier again. Yes, please. Okay, this looks okay here to me.
A little bit
Okay.
in, if a little bit in.
We're not very close.
Yes.
Okay.
So question,
We are far out.
here the,
It's like
the
three struts out.
ostium
We
and
can go in
proximal
just
part of the
also
left
to
main
overlap the.
has not much disease,
I got
right? I mean, when you do stenting like this, I mean, do you go back to the ostium of the left main or
Yes,
you stop
please.
at the mid?
Well, to cover the ostium, I
Yes,
think
please.
you should do it all the time.
Yeah,
Because
2, 4,
you'll
6,
never
please.
be able
2, 4, 6,
to
please.
stop in the
Save that
middle.
one. 2, 4,
Sometimes you
6,
get
8, 10,
oversizing
12,
in the
14.
middle part and you end up by another stent. So I think
16.
it's preferable to cover
Down, please.
the ostium every time you put a stent in the left main, unless in very
Long.
limited situations that it's a very long left.
I think it depends on.
know what you do.
I think it depends on the IVUS images. In this case, per se, the lesion does not extend all the way to the ostium. I think putting a stent in the healthy area in the left main, allowing you to do it pot.
Yes.
So enough pot. So
Go to spider, please.
It depends also on the available NC balloon.
we can check
Sometimes
the,
you
ostium
have
of
an
the
8
SX
millimeter
to remove the
NC
wire,
balloon, so you can do
before the
it.
pot.
But if you have only 12 or 10, I think it's
We
better
will
to
just
cover
see
the
first what happened.
Balloon 5.
Yeah, we can remove the wire pot and then.
Yeah, we'll keep it as a marker just to know
Yeah,
what
yeah,
the balloon.
Yeah.
It helps me to keep it before doing pot. But I will keep till I see my balloon positioning, and then I will remove it.
Yeah, my only concern with this is that it pushes the guiding and
So,
and hits
Arif?
I will
Yeah.
just try to do gently,
That's-
advancing, and once I have it in, yes.
Just explain to us. I mean, you
How many-
did
can you remove me the time, please?
stenting.
5 minutes,
What's your
10
next?
minutes more, yeah.
This is not.
Arif?
Sorry, Mohammed. I was watching the.
Okay, you did the stenting now. What's your next move now?
I'm potting the left main ostium, and I removed gently the wire, the jailed wire, which I don't believe it is quite jailed because it is just a 4. So I just will use it just a landmark for me, and then I remove that wire. Which one was it? No,
This one is the black one, the cyan blue.
no, cyan blue. We'll leave it. Show me the distal,
No,
please.
cyan blue is in the
Okay,
LCA.
this is the LED, and we'll go with this one out. See, little jailing, but not much. I kept my guiding outside, not to damage the proximal edge of the stent. Yes, please, small before, just to make sure we didn't move much. Yeah, I think we are good here. Go, please, 2, 4, 6, 8, 10, 12.
What's the size of the
14.
bot balloon?
5, 12, 5, 10, sorry.
14, okay, down.
14, 15.
Yeah,
10 minutes.
Telling the time is 10. My dear, I'm asking about the size of this. You are pointing. I say, what's the size? And they show me 10. So I don't know what is going
No,
on.
it's a 512 balloon.
Again, please. Again. It's a 12.
512.
Yeah, that's what I'm saying. Okay, good. Go to 16, please. 18.
Okay.
Down, please. Okay, so
Now,
Now nothing. Now we push our guiding in little bit.
It's good, Arif, that you showed us that with the pot, the distal part of the balloon, the distal marker should be at the distal edge of the bifurcation rather than at the proximal part. And you did it the
Can I have
right way.
Iris, please? Thank you, Anna. Yeah, there are a lot of things to be considered in those cases, frankly said, that can, okay. We'll do an IVUS, please, and go Ario Cordal, please. Now is the discussion for the panel. How many would go do something, opening, what Mohammed raised before.
Nani?
Frankly said,
ACT.
I don't do anything.
ACT.
It's not our first time. I did many cases like this, just with provision and not to open, especially with the large cell size and this. Usually nothing happened.
The OM is nice.
And the OM is back. My friend is saying, don't touch that OM.
We are good.
We did already DCB to that part anyway before. So there is some drug inside that epithelium. Well, I think that will sustain. And LAD distal is quite distal, and I don't want to do anything.
Screen.
So, yeah, 1 second, please. I'm just trying to do the final IVUS. So who will do more? Let me hear from you, Mohammed. Who is ready to go for more aggressive?
Me personally, I'm not happy with the ostium and the proximal circ. I mean, considering this patient is not going to have another, I mean, he's not a surgical candidate. So you want to make sure that all his vessels, especially his left dominant, that you don't miss anything.
I tell you, Mohammed, one thing. First of all, this is an open cell design. This is a single wire stent, and the access to the circ will be really no challenge. We can see here the access of the ostium of the circ we saw just now, quite patent, and there's no dissection. This lesion was there from before, and I don't see any really significant carina shift there. This was from before. The flow is 3. We will call the patient certainly as an outpatient and follow him up. But for the timing, you know, the patient underwent really complex situation before we went live. And he is on renal guard, he is on IVAC, a lot of things. So I don't think doing anything to landing in more complication for this patient for unnecessarily at this stage. We would consider that circ later on, but re-accessing that, I don't think will be a big and major issue. Let's have one ariocranial, please.
Sure. Any other opinion?
With all respect to all your comments, sir.
Gabriel.
Well, basically,
Can we keep the
I agree with
keep the
this,
IVUS on the big screen, please?
conservative strategy because it's also a high bleeding risk patient. So less stent, less risk. Just to ask you, would you consider to finish with treating the distal LAD with a drug-coated balloon or not?
Again, the same argument I have. At the moment, this patient was served nicely with establishing flow through 2 tight lesions, and that distal LAD, very distal LAD, to have any kind of flow is there. So I don't think it's necessary at this stage. We can call him back later on and reassess him. But I don't think prognostically, frankly said, that this will affect his prognosis much.
Well, I think out of the safety of the patient comes first. And I think you spent a long time during the procedure, and you did a great job in the left main and LAD.
Yes, more.
I agree with you. We can stop at this stage.
Just 1 minute. I can't hear you, Dr. Adil. What did you say? Sorry.
You can't hear me? Well, I'm saying the for the safety of the patient, we can stop at this stage with an excellent left main and LAD. But I think he will need further workup later for the distal LAD, maybe the ostium of the circumflex to be evaluated in a second session. I think so.
Yeah, and if I may comment, if you can see here on the IVUS, indirectly you can image the ostium of the LCX, which is from this cut, which is not, of course, very accurate or very dependable, but at least gives us some idea about how the ostium of the LCX looks like. And as you can see here, it's widely patent behind the left main stents. Gives some reassurance, not 100%, but gives some reassurance that the ostium of the LCX doesn't need any treatment at the current stage.
I totally agree on this.
Okay, great,
Okay.
Arif. Now,
Are we
Arif, for
okay
the
with that?
hemodynamic support, you, I mean, remove it immediately after the
I will remove
procedure finish?
everything. I will remove everything. I am so grateful that we had this IVAC in place. It helped us a lot to maintain the blood pressure until we managed. We had to intubate the patient electively. Patient went really dramatically to hypo and but with the support of this, we were able to overcome the situation. So I'm really glad that we were prepared for this. This is what the message of this live case was. Even a very high-risk patient in this age, if you prepare and plan the case nicely with renal guard, with the left ventricular assist device, with whatever tools, device, stent, everything, then your chance of getting really getting patients safely out of the cath lab is quite high.
Okay, we have one comment or question from the audience. Muhammad?
Yeah, Arif, it's Mohammed here. Great job, fantastic
Hi, Mohammed.
case. Couple
Thank you, sir.
comments. I think I totally agree about the ostial circumflex. There's always tomorrow. You could always come back and do something if needed. It's TIMI 3 flow. There is some disease there, but I don't think anything needs to be done. The comment I want to make is about the mid-LAD. I think we're trying to kind of curtail what we do. Exit of the stent and the distal flow is a huge determinant of the long-term outcome, and I think this is what Gabrielle was trying to allude to. And I think it will not hurt. It will not take too much work at a low pressure, non-compliant balloon, just to open the flow distally. So the distal LAD is quite good, because now we've opened the proximal LAD in the circ and the left main. The flow is quite much more vigorous, if you like, and you want to make sure that the distal flow is quite good. That would be my thought, but you know, I totally take on board what you're saying. You're there, you know much more than us how the patient was and how it is. All what I'm saying, the distal flow is important.
Certainly, Mohammed, I would not argue that, but as I said, there are 2 points from my perspective. First, this patient had really complex procedure today. He's on the table for 2-3 hours. And I don't want this kind of calcified agent. I may have some kind of complication distally, which I want to avoid at this stage, really. I'll call him later on, and I can optimize my OM, my distal LAD, whatever I think it is really needed. But for this, now for the time being, I think he has been well served.
Thank you.
This is my
Thank you,
opinion, with
Arif.
full
Thank you.
respect.
Great case, as usual. Thank you, and thank you for all your
Thank you,
team.
sir. Thank you, dear. Thank you, everyone, and all the success. Wish you all the success. Thank you. Have a good day.
Just a comment. I think the case was well planned, well done. You do have a severe depressed LV function. You do have a CTO RCA, heavily calcified left main tail. LAD mechanical support was used, and was excellent choice to do. You do have a heavily calcified LAD with 180-degree calcium in the ostial LAD and deep calcium, and the debulking decision was made, and that's an excellent choice that they used shockwave. And excellent choice. We had an excellent final result. So well done.
Thank you. Thank you very much. Thank you, everybody.